Dr. VASAVADA. So he's here to deliver this AIOS Daljit Singh Endowment lecture. Daljit Singh, as we all know, was one of the pioneers of cataract surgery, and he is famous for his iris claw lens. So therefore, since it is pertaining to cataract, we thought none better than Abhay to deliver this endowment lecture on AIOS Daljit Singh Endowment lecture. Abhay?
Thank you, Daljit and Partha, for such a wonderful concept, and I wish this will keep improving as the time goes, as we keep learning and the logistics and other things, that we give a deserving respect to those legends on which we deliver the lectures. But I'm really privileged and honored to give this, and Dr. Daljit Singh was known for his innovations, of which the iris claw lens was worldwide, and he really was very popular. He also devised many useful gadgets and small instruments at that time, bimanual IA, for example, and it changed the extracapsular cataract surgery, and then also on the lymphatics, the subject which very few people got interested in it. So I can go on his innovation, because he really was a visionary, he was an innovator, but at the same time he was very direct. He was very bold to take the risks, and good part is that he was taken up very well by the society members, because he was a great human being. So I really salute to him and his family, who has continued, I believe, in doing these maverick tricks, as if were, and this is one of those ultimate iris claw lens that Kiranjit and Ravijit have developed. So I do receive research grant support from Alcon, but it has nothing to do with this, my presentation, which is mainly on the years that I spent in the subject and the life that I think is important for the younger people to share. And before I do that, I acknowledge the educators worldwide, the experts in the subjects, my colleagues, trainees in particular, but most importantly the patients who really gave me all these things. But if I have to name one or two persons, it would be Dr. P.N. Nagpal and Dr. G.N. Rao, who really have influenced me individually speaking, so I thought I would recognize them. But what my philosophy has been to from the practice that I started doing to professoring in my life, so that I can improve myself primarily, and also help the science and hopefully benefit the patient. So I think doing that in a private practice, and I was determined to do that right from the word goes, and that's basic philosophy. And the lessons I learned as a clinician, as a surgeon, and as a clinical researchers are many, but if I enumerate very fundamental things as a kind of a general philosophy, I think it's very fundamental, elementary, that we try to be helpful and sympathetic, give enough time, and listen to the patients. You may have 200 patients waiting in the OPD, and I saw that many of these very popular organizations where they're loaded with the patients. So that's an issue. But approach them not as an eye disease, but and a general well-being, their health, and take interest in them. But it's saddening that human aspects of medical practice is really going down worldwide. So we are not the only one, but this is something we need to pay attention and try to address as much as we can. And formulating a team with the other medical specialties, our own super specialists, is something now a necessity, even if you don't believe in the academics and so on. And it's you must keep all the time, when a patient sits across you in the slit lamp, do what you would have done to you and your family, and always respect when you confront a clinical scenario in a patient, respect your colleagues and support them if you, as much as you can, whether it's a medical intervention, surgical, and be a family, be a team. That is very important, and I think it's getting sidelined with this competition and with the stress that we all go through this in our presently world. But the surgical tips are innumerable. I don't want to go through the details, but you must recognize there is a need and necessity to keep refining our performance as a clinician, as a surgeon, a researcher, and make this very predictable, consistent, and better. And the first step would be the pre-operative evaluation or pre-intervention evaluation. Give a dedicated time slot, not as a routine OPD. We have a separate time slot for these where the consultant, the technicians, all are separate. They have nothing to do with the OPD. They just have plenty of time, 10 patients in 4 hours, and they spend all the time so that we understand and deliver what is expected. And there are many, many technical details as a cataract surgeon, and same thing would be applied to all the specialists. But I just want to take a few minutes on this attention to the posterior capsule, and that is something is now a kind of evolution in last recent time, and you can perform it in several ways and take the advantage of that capsule surgery. This is one of these which is known as the optic capture, which stabilizes the lens well, but also in children would dispense away with the need for vitrectomy and still maintain the posterior capsule clarity and central axis. So you can consider that in various applications. This is a traumatic cataract with compromised bag. Posterior capsule is intact. And still I performed a PCCC because otherwise the lens stability would not be very predictable. So this is the same eye, well centered, well stable IOL. But this is something which is very fresh and new. I don't have enough experience. I've done less than 10 of these cases. But if you see a very advanced angle closure glaucoma, which are likely to develop malignant glaucoma, as you can see here, with all forward bulge and everything, and you really don't know what to do. People do vitrectomy, do capsulotomy, and so on. But if you approach it differently and put the haptics in the ciliary sulcus of a 3-piece IOL and capture through ACCC and PCCC, please quiet there, please. The guys, be quiet. You can really reconstruct the anterior segment and rotation of ciliary body and so on, and no fear of malignant glaucoma. So I think, in summarizing, keep in mind performing the surgery on the posterior capsule can be rewarding at times, and I think it should be in armamentarium of every cataract surgeon or any surgeon wherever you face with this. And likewise, there are many little tricks all of us have developed several. I will just keep up these, and some challenging cases need to be dealt with very methodically in a step-by-step manner, and learn from the stalwarts and the experienced colleagues that will teach you how to deal with this. But one of the things with the vitreoretinal surgeon already had that in terms of the IOP, the set and thing. The cataract anterior segment surgeon never had that. Then we realized that if you put a very high bottle height, you produce a lot of high IOP and fluctuation versus a low IOP and low flow rate and so on. So I think that has been translated onto the impact of these procedures on the anterior and posterior segment of the eye, and make it very safe and a controlled procedure. But finally, of the techniques and surgery, I just want to pay attention to this cortical aspiration, which has been taken as a rut. I never paid attention for last 40 years. I just, what was happening, I was removing the cortex. I didn't pay attention how I should do it and why we should do that. So I think our colleagues reported this technique, they called it POPS technique. What it means is that aspiration port is positioned under the anterior cortex, occluding the cortex, and then taking it a little bit posteriorly. Remember the anterior capsule and the posterior capsule. Anterior capsule is an epithelium and a villi which bind the anterior cortex. Nothing like that on a posterior capsule, very free. So you need to detach it, and because they are like that, if you pull it radially, you can produce stress. Instead of that, take it posteriorly, detach it, the anterior cortex from the epithelial attachments, and so therefore you need to displace the aspiration port which is occluded posteriorly, and then swipe it from the fornix to reduce the stress on the zonules and also to remove the epithelial cells as much as you can. This is the first thing. Position the aspiration port under the anterior cortex. You can do it same in the coaxial as well, but bimanual would do a better job. You can concentrate on animation on the side peep, occlude it with 100 millimeter or so of the vacuum, and then that this is a very critical step. Tilt the aspiration port posteriorly, because you can understand the cortex is attached to the anterior epithelial cells. There are no epithelial cells in the posterior capsule. So you need to detach it in a right ergonomical direction, and that's what it is. And then you swipe the fornicial attachment with the epithelial cells and the anterior and posterior capsule. And once it is detached substantially, the next thing is to just push the pedal and finally aspirate with the way you want to do it. And why we should be doing it? Dr. Samresh Srivastava showed it very elegantly on this animation, where in a conventional cortex removal where we pull it radially, quite often because of the high aspiration force, those cortex can detach it and leave behind the epithelial cells, which are the predecessors of the posterior capsule opacification. Instead, if you take time and if you go through that ordeal of that technique that we just mentioned, there are more chances that you will be able to remove the epithelial cells a little more extensively or quite often completely. But this is something which was a nightmare for me, and I learned from my posterior segment colleagues. And this is number one, that you must stain the vitreous triamcinolone. And every time I had a vitreous for many years, my PCR would enlarge. It was started with small and suddenly it becomes large, and I never understood why. But once I picked up the pars plana approach, where the vitractor goes to the pars plana but irrigation from the anterior chamber, things change. You can do a sclerotomy with lens knives with peritomy, or use this kind of devices which will allow you to use repeatedly entry and exit. But notice, it simply drains into that vitractor, that vitreous, and now I can remove the cortex as if there's nothing has happened, and complete that procedure. I show it once again to illustrate and highlight how less traumatic it is to the posterior capsule tear, but also to the posterior segment. This is what once again Samresh showed us, how adequately you can remove the anterior vitreous from the chamber without impacting the tear. And what happens if you do top-down approach, where you do it from the front because of the unique anatomy of the vitreous. So I think some of these tricks I learned over the years, and I thought would be interesting for you. Finally, we don't need to be a researcher. What is a research? Research is nothing but have a curiosity in mind and try to address that curiosity. And how do you do that? The best research is by a methodical, well-taken observation. Nothing can beat, no bench research would beat that well-taken methodical observations. And then you can translate that with the bench research, if you have, into the real world. But it may find that intimidating, but that clinical research is not. It is something that develop common sense and try to address the problem. Whatever we do, remember, this is what we are doing all about. We are not doing to increase our practice or have a glamour or so that I can speak from the podium, but it is for these people that we are doing. And finally, this is what I learned hard way later on, and there are young guys I see who keep doing it, and they were enlightened earlier than me, but keep taking care of yourself. Nobody is going to take care. We are learning hard way. Nobody bothers about us. And take care of your ergonomics when you examine, when you operate. Try to remain fit, whatever you want to do, whatever procedure or activity you want to do, but try to take care of yourself. And I'm blessed with those people who are like-minded here, and we keep doing such activities at our place, not very regularly, but sometimes. And I thank them, my team at REH, and I also thank my family, and I owe them a lot, both the families. And without their team effort, clinical and academic success is hard to come by. Finally, I hope, like late Dr. Daljit Singh, I also wish to leave behind a legacy for my younger friends of developing a curiosity when you see a patient or talk to them, sharing it with your colleague. That's very important. Don't keep it to yourself. You will not grow otherwise. And grow, therefore, with each other, and try to be keep your feet on the ground as much as you can. So thank you so very much for your patient hearing.